So why calcium scan? So the reason for that is that we have traditional risk factors, right? We look at people who come in and say, who is at risk of heart disease? We would say people who are diabetic, who are smokers, who have high blood pressure, high cholesterol, and family history. And then on the other side is putting somebody through a calcium scan. So what is a calcium scan? So a calcium scan is a CAT scan of the blood vessels of the heart. It's a low cost, low radiation test. The radiation that you get from that is about the same as that of a mammogram. And out here the rolling screen is showing you me scrolling through and looking and seeing whether this person has calcium. And what you can see is that that person actually does not have any calcium. And you can see my marker out there, or only I can see it?
I see the red pointer.
The pointer you can see. So you can see that this is the LED. This is the blood vessel going to the front of the heart. It's free of calcium. If there is calcium, it will look like a white spot, like this is the spine. These are the ribs, so it will look like a white spot. This is the right coronary this is the right coronary artery. That's the beginning of the right coronary artery. This is the downstream portion of the right coronary artery. And this person at age 47 is free of calcium. So in order to drive this point home as to why calcium score is so much more important than risk factors is that this group took 540,000 patients. And these were the patients who had they had a heart attack. And they looked at the number of risk factors these patients would have. And to their surprise, fully 14.4% of these had no risk factors. Since these are having a heart attack, these people are having a heart attack, you would expect that the majority of them will have many risk factors. And the majority of them, that means greater than 4 risk factors, was present in only 4.1% of people. So that means that risk factors are not as predictive of you having a cardiac event. How does the calcium scan compare? So here is different people with different levels of calcium in the blood vessels of their heart, about 6,700 people. And if you had a calcium score of 0, and this is extending out to about 5 years, the number of heart events like heart attacks, stents, bypass surgery, or cardiac death was pretty low. It was like right around 1% at 5 years, or maybe even lower. But if your calcium score was about 300 or greater, you had about a roughly 12% risk of having some kind of a cardiac event within that 5 years. So this is quite dramatic, and people said, let's kind of make this available for everyone, as many people as possible, and let's kind of try to define what 0 calcium score is, what mild amount of calcium or mild to moderate, and what severe calcium looks like. So on the left panel is a normal blood vessel that you have seen. On the right panel is one of my friends who has a spot of calcium in the blood vessel that supplies the front of the heart. This is the LED. If that closes, that's called the widowmaker. And this person has extensive amount of calcium. This looks like actually bone in the blood vessel of the heart. You can see that the LED is like severely calcified. This group collected information through several different studies, 5 different studies. And what they found is that, so there is MESA study, which is multi-ethnic study of atherosclerosis, and then the Becker Munich study, and then somebody from South Korea. And they gathered about roughly 15,000 patients. And what they found is that if you had a calcium score of 0, your 10-year event rate, that means if you have 0 calcium score, the chances of dying in 10 years was roughly around 1%. What does that mean? That means if you took 100 people with 0 calcium score, followed them for 10 years, one of those 100 would have a cardiac death. That's pretty low because a lot of things can happen in 10 years. This is an event rate, but I think it's also similar for death. I mean, different studies have calculated, but this is a 10-year event rate. You're right. On the other hand, if you had a calcium score of greater than 1,000, the chances of having a cardiac event, and Kathy pointed out it's not death but cardiac event, which she's right, was 37 times that of 0. 37 times. We looked at somebody with 0 calcium score. It's the same slide that's repeating. They're 47. So calcium score should always be viewed in the context of your age. If you are low, if you're less than 50 years of age, as you will see in the slide. So these people gathered about 10,000 patients and did a calcium scan on all of them and tried to find out how they would stack up in terms of each other. So let's take this 47-year-old person, he's male. So we go into the group of 45 to 49, and you would find that he has almost a 50% chance. Like if you take a random 47-year-old person and you scan them, there's a 50% chance that he'll have a calcium score of less than 0, or 0 or less. So having a 0 calcium score at age 47 is not as great as having a 0 calcium score at age 65 if you're a male, because almost no male at that age will have a 0 calcium score that easily. Okay? Now here is a 67-year-old female, and this is all information from our practice, but the names are not disclosed. And you can see that the LAD is clean, the circumflex is clean, the right coronary artery is clean. And for her, if we go back to that nomogram again, or the percentile nomogram again, you would find that this places her in the top 25 percentile of her age group. That means that this lady is almost at age 67, she's pretty good. You know, she is in the group of people in whom calcium is much more likely, so she is somewhat better than most of her peers. We've talked about 0 calcium score, so I thought I would talk about the power of 0, like the power of 0 calcium score. So there have been a number of different studies, and I've listed out each of these studies out here. This is one by Raggi, there's a St. Francis Heart study, the MESA study, then this is a meta-analysis. That means that you put a large number of studies together. And this one is about 20,000 patients. And in all of them, we are looking at an event rate at 10 years. What's going to happen to you at 10 years if you have 0 calcium? And the event rate is pretty close to 1%. Like we said, 1 out of 110 years will have a cardiac event. So if you go up north and you are with one of Dr. Jaroudi's colleagues, Khurram Nasir, he put together this data, and this is a pretty impressive study. So what he did was that he looked at information from about 45,000 patients and stacked them according to 2 factors. One factor is calcium score, from 0 to high calcium score. The second factor he looked at is risk factors. How many risk factors do you have? How many of these people have high blood pressure, diabetes, smoking, family history? So this yellow graph, you are seeing that these people have 0 calcium score, all of them. But as you move along this line, they have more and more risk factors. So this person may have diabetes, this person will have diabetes with hypertension, this person will have diabetes, hypertension, and smoking. So if you had a 0 calcium score, what would happen to you? Now this is 1,000 person years, so it's a way of telling what is your risk. But if you had a 0 calcium score and you had a lot of risk factors, now I'm letting you look at that slide, what would be a risk of having an event, low or high? Low. Excellent. So in other words, even though you're smoking, you're a diabetic, your risk of having a cardiac event is low if you have a 0 calcium score. On the other hand, if you have a higher number of risk factors and your calcium score is increasing, so in other words, this is that column that we are looking at. Risk factors are increasing, calcium score is increasing. What's going to happen to your risk of having a cardiac event? It's going to go up dramatically. And if you have 0 risk factors, in other words, you don't have diabetes, you don't have high blood pressure, you don't smoke, you don't have family history, and your calcium score is increasing. In other words, you have no risk factors and your calcium score is increasing. What is the risk of you having events, low or high? High. So in here, Dr. Nasir showed that calcium score is a lot more important in predicting cardiac events than risk factors do, just like we have said. So to put it in numbers, and I think this is not survival, this is probably events. I made a mistake. Oh, actually it's mortality rate. So in other words, it's survival. So if you had 0 calcium score and 0% risk, your 10-year survival is 99.7%. But if you had more than 3 risk factors and you still had a 0 calcium score, you had a 99% chance of living. So many people ask me, I have a 0 calcium score, how long is it going to remain 0? So this is a study that evaluated that, and it says that if you have a 0 calcium score, the conversion rate at about 4 years is only about 11%. So there is a 9 out of 10 likelihood that at 4 years, if you're rescanned, you will still be 0. This study looked at people coming to the hospital having a heart attack. So when they had a heart attack, they had a calcium scan, and their prediction was that the majority of these patients who have a heart attack will have some amount of calcium in the blood vessels of their heart. So out of the 110 patients, 105 had calcium, but 5 did not have any calcium and still had a heart attack. So now that's a little bit of a downer, right? I mean, like,
Yeah.
okay. So what I mean is that having a 0 calcium score, and this is my experience because when I went to the first low carb conference in Breckenridge, there was a 30-year-old Indian gentleman who had a heart attack and had a stent. And at that time, calcium score was coming over, and asked him, what was your calcium score? He said, I had it scanned the day before. When I went in with chest pain, it was 0. I went home and then had a heart attack and went back to the hospital. So having a 0 calcium score doesn't mean that you suspend common sense, because if one of you has 0 calcium score and you have symptoms, fatty liver, if you are insulin resistant, and most of you know what insulin resistance is, if you have high amount of fat in the blood, like triglycerides, low amount of HDL, I say this calcium score is not very comforting. On the other hand, I want to show you that if you have a high calcium score and you have good metabolic health, in other words, you are practicing fasting, what I would prefer to call it as a low carb diet, the politically correct terminology may be less sugars and processed food. And if you have low triglycerides, that means low amount of fat, you're fat burning, you have high HDL, you're physically fit, I'd like to show you that that calcium score is actually not a death sentence. Now calcium score, in that my friend who was 30 years of age was 0 because in the beginning when you're building up plaque in the blood vessel, especially in young people, it's a soft plaque. It has not had time to calcify. So out here is a picture of the blood vessel of the heart. It is severely stenosed or narrowed, but you can see no calcium around it. The calcium would look like this, like it would look like bone. And this is like an imaging, which is an optical OCI, optical coherence imaging. And you don't see any calcium around that blood vessel, even though it is narrowed. On the other hand, this person has calcium, the blood vessel is not narrowed, and the calcium is out on the periphery, it's on the outside. So in other words, this person remodeled their vessel. The blood vessel expanded and the calcium remained on the outside and didn't encroach onto the lumen. Later on, we will try to find out why that happened. The question that we just posed to ourselves is that I have calcium. Does that mean that it's restricting blood flow in the blood vessels of my heart? Are there things that I can do to prevent the calcium from blocking my blood vessels or the plaque from blocking your blood vessels? Can I do anything to prevent calcium buildup? If you have low calcium, mild calcium, and high calcium, how likely are you to have a positive stress test? So this group has very little calcium, less than 100. This group has middle level of calcium, 101 to 400, and this group has greater than 400. You can see that the likelihood as the calcium score increases of having a positive stress test becomes higher and higher. This is a 67-year-old gentleman whom we just scanned. He's been on statins for 30 years. He's got a very low LDL, but he's metabolically not healthy. He's got large amount of fat in his blood. His good cholesterol is low. He's pre-diabetic. He's coming in with chest pain. He says, I cannot walk on the treadmill. And he does not want to do a chemical stress test. So when you calcium scan him, and you can you see, guys see bones in the blood vessels of his heart? You know, you can see that when it scrolls through, this is the right coronary artery, this is the circumflex, this is the LAD. And he really does not need a stress test. This person with all these symptoms should go to a heart cath. Some people, when they build blockages, will make their blood vessels narrow. That's called negative remodeling. In other words, the blood vessel shrinks in size where there is plaque buildup. On the other hand, many people build calcium, but the blood vessels expand to accommodate the plaque. Now I'm using calcium and plaque as similar because they signify more or less the same thing. So you want to know what can you do even though you're building calcium to get positive remodeling. In other words, the blood vessel enlarging to accommodate the plaque so that you don't get restriction to blood flow. So when the plaque is minimal, the restriction is minimal. But as the plaque grows, the blood vessel tries its best not to narrow the lumen. In other words, it grows to accommodate the plaque without restricting blood flow. Because the size of the hole or the lumen through which blood is flowing here and here is not very different. It's just smaller by a very small diameter. So as the plaque progresses from normal to mild plaque to moderate plaque, the blood vessel enlarges. You can see that the blood vessel is enlarging. It's called vessel expansion to prevent the blood vessel from narrowing. But at some point, these plaques can rupture. With the flow of blood, the lining can break up, and when it ruptures, it forms a blood clot. When it forms a blood clot, it becomes narrow, and this is what leads to a heart attack. And a heart attack involves a lot of inflammation. When there is blood clot forming, there's inflammation. And inflammation, what it does is that when it heals, it leads to scarring. And when it leads to scarring, it will cause some shrinkage of the blood vessel. I want you guys to now tell me, and you can cheat by looking at the slide, what can you do to prevent negative remodeling even though, let's say, there are so many factors, like we've talked about diet, fasting, exercise, and family history, which we cannot control. I mean, if somebody knows how to control their family history, that's different. So genetics, stress, sleep, there are so many factors that would lead to plaque buildup, which would get calcified. So many of them are not in our control. But some of them are in our control. So what can you do to prevent plaque buildup and have positive remodeling? Exercise. So one of them, exercise, is out there. What are the other ones? Is good metabolic health. You practice good metabolic health, and I'll take you through some of that. The question that comes about is that my CAC score, my calcium score, is increasing over time. Am I at greater risk? What do you think is the answer? Yes. So this is about 500 people who were asymptomatic. They had a calcium score roughly around 300. All of them were put on statins, all of them. And then they were followed for 3.2 years, and 41 out of that 500 ended up having a heart attack. Do you know what the difference in cholesterol level was between the group that had the heart attack and the group that did not have the heart attack? LDL?
Four.
Nothing. So their LDL did not change. The LDL was the same between the two groups. But what was different between the two groups, the group that had the heart attack and that didn't, is that the group that did not have the heart attack, their calcium score remained stable over the 5 years of that 3.2 years of that study. In other words, their calcium score did not increase. On the other hand, if your calcium score increased from baseline, from when you entered the study, the chances of you having a heart attack were much greater. If you had a high calcium score in the beginning and the increase was dramatic, the chances of you having a cardiac event was very high. You can see that it is roughly at about 0.65. So that's about a 35% greater likelihood. High calcium score with progression almost means that you had almost a 50% likelihood of having a cardiac event. How many of you have faced with this? I have coronary calcium because of this. My doctor has advised that I need to take a statin. Otherwise, they say, you're going to do very, very poorly. Nobody? Somebody raised their hand. Go ahead, John.
Dr. Lee, all the people in this room are your patients.
Several people come to me saying that my doctor says I have calcium. That's like death sentence, take high dose statins. Now my question to you is that, do statins actually reduce coronary calcium? I mean, all of you have heard me over time. Do statins reduce coronary calcium or increase it? They increase it. So how do they increase it? So this is a mechanistic slide. In other words, there are 25 different steps in the body to make cholesterol from scratch. 25 different steps in the body to make cholesterol from scratch. The statins stop cholesterol production at about the 5th step. Not only cholesterol is important for the body, but several of the other compounds that are made in those 25 steps are important, and one of them is called isoprenyl PP, and that one converts vitamin K1 to K2. How many of you heard that taking vitamin K2 is good because it will reduce coronary calcium? Okay, so we'll talk about that in a little bit. So statins will prevent the conversion of vitamin K1 to K2. Now, how many of you have heard that statins work because they reduce inflammation? A lot of you. But there is also biochemical information that statins increase inflammation because they reduce glutathione, which is an anti-inflammatory protein. So here is the evidence. Now the evidence is not very good because nobody will fund a trial to look at increase in calcium buildup with statins, but this is a VA study. There were 197 patients with type 2 diabetes. They were about 61 years. They were followed for around 12 years. So that's a long follow-up. Now some of these patients were like you. I said, statins is causing myopathy, causing mental fog. My doctor is not really too keen on it. Should I take it or not take it? So they took the statin irregularly. But there were other groups that said that, hey, the mainstream advice is to take statins. I am already a diabetic. I should take statins. So in the group that took statins more regularly, the increase in calcium was much more dramatic and significant compared to the group that did not take statins. So here is evidence that statins do increase calcium. Is that the only study? No, there are a few other studies. This is atorvastatin at 80 milligrams. How powerful is atorvastatin at 80 milligrams? Very powerful. It can cause mental fog, myopathy. The higher the dose, the higher the likelihood of symptoms. So there were about 49 patients in the placebo group, 39 in the treatment group. The reduction in LDL was 53%. In other words, your bad cholesterol, or the so-called bad cholesterol, went down by 53%.
Relative?
No, this is absolute reduction. So in other words, if you want to go on a statin, I can reduce your cholesterol by about 50% with a statin and 70% with a PCSK9 inhibitor. Absolute numbers. But the calcium increased by 26% per year in the group that took statins and 18% per year in the group that did not take statins over a 36-month period. This is simvastatin. This is another statin. It's less potent. So 80 milligrams of simvastatin would be like about 20 to 30 milligrams of Lipitor or atorvastatin. Small number of patients. LDL reduction by 42% in the statin group. Calcium increased by 9% per year compared to 5% in the other group. Now there is cell culture study. In other words, if you take the blood vessels and you take the cells that make the blood vessels, which are called smooth muscle cells, and you culture them in a dish, and you expose those cells to atorvastatin, which is a statin, these cells will take up calcium. The higher the dose of atorvastatin, the higher the amount of calcium buildup in these cells. Is that all? Is that just calcium buildup? So these cells were taken and they were exposed to amlodipine, which is a blood pressure drug, at fairly high doses. And what was found is that the cells were living happily. There was no cell death. The cellular nuclei, that means component of the cells, were all good. But when they were exposed to atorvastatin, the cells started dying. And when you looked at the cells in detail, there was nuclear fragmentation. That means they were in the process of going through what is called apoptosis or cell death. We talked about statins. Statins don't reduce coronary calcium, they increase it. There's a lot of propaganda that says that the reason statins increase coronary calcium is because they are stabilizing the plaque. They're making the plaque less vulnerable. I can tell you, have scanned the literature, there's no data that does that. Somebody just comes out of this theory so that you can justify the use of statins. What about exercise? Now, how many of you have heard that high volumes of endurance exercise is actually detrimental for you? So yes, there's data on that. If you take 100 people who do marathon running or cycling, like a lot of cycling, there is about a 10% risk of having atrial fibrillation in these people over time. That's a lot. That means 1 in 9 will have AFib. Now, of course, it's paroxysmal and it can be taken care of. Now, it can also increase allostatic load. What that means is that if you're exercising a lot, your stress hormones like cortisol or the fight or flight hormones may go up. So large amounts of exercise is detrimental for you in some ways, but what is the relationship with coronary calcium is what we are trying to explore. So this is a study in about 10,500 patients, high volume of exercise. You can see that their age is pretty similar. So these were graded from highly active, moderately active, low exercise to no exercise. So high exercise people on a scale of 1 to 10 will say, I exercised from 7 to 10. Moderate will say 4 to 7. And low exercise will say 1 to 4. And sedentary individuals, of course, don't exercise. But the people with the highest amount of exercise, do you see their benefit in them? The risk of hypertension was so much lower. Diabetes was 5 versus 14. Resting heart rate, a slower resting heart rate means that your heart is more efficient. 62 versus 77. Their body mass index, which is hidden, I don't want to move that because the minute I move it, it will freeze. But take it from me that it was 31 versus 25. Also, they looked at some real good markers, triglycerides, which is fat in blood, good cholesterol, which is HDL, fasting glucose. You can see that these people who were highly active had lower triglycerides. That means they were metabolically more healthy. They had higher HDL, which is a good cholesterol. They had lower sugar levels. But look at their LDL. It was really not very different. So high volume exercise, at least in this study, and there are several studies that show that it does increase your coronary calcium to some degree compared to people who are moderately active or who are low active, low exercise group. But a little bit better than people who are sedentary. You would say that, am I trading something? I'm giving a little calcium, but I have lower blood pressure, lower triglycerides, higher levels of good cholesterol, less likely to be a diabetic, and more normal body weight. This is looking at event-free survival in these people up to 10 years. The top line out here is people who did extensive exercise. That means the tens out there. Their risk of dying was much lower than people who did not exercise. So even though high volume exercise may be detrimental, maybe you can watch some of our YouTube videos in which we talks about how to do optimal exercise. So when you exercise high volume, how to rest, how to make sure you get good sleep, so that when you go out and exercise the next time, that you're not increasing your stress hormones.
Whose video is that?
We have a video out there. If you had 0 calcium score, it didn't matter how much you exercised or you were completely sedentary, your risk of dying was the same. On the other hand, if you had some calcium, then exercise attenuated that risk. The highest volume exercise people had the lowest risk. Now that was for a calcium score of 1 to 399, but it was much more dramatic if your calcium score was greater than 400 because the benefit of exercise was quite dramatic. Moving along, exercise increases calcium score, but does it actually reduce the amount of plaque? So now this is a little bit of a contradiction, right? You have higher calcium, but lower plaque. This is a CT angiogram, which means that you actually not only do calcium scan, but you get an angiographic appearance of the blood vessel through coronary CT angiogram. So this is a calcium scan. So these individuals, 252, which were divided between inactive, low exercise, moderate to high exercise, underwent both a coronary CT angiogram as well as a calcium scan. So here is what is called a soft plaque. It's not calcified. Here is a calcified plaque. And here is a mixed plaque. It has a mixture of both calcium and soft plaque. So they looked at all three of these things. So what did they find? They found that people who had moderate to high exercise had lower risk of having severe narrowing. So greater than 70% narrowing was there in 27 of the inactive, whereas 9 of the highly active people, moderate to high activity. Now there is another thing that CT coronary angiogram says that it can tell you, which is called high risk plaque. A high risk plaque is one in which the plaque has characteristics that it can rupture. When it ruptures, it causes blood clot, it causes cardiac events. In this study, they said we can identify high risk plaque, and people with moderate to high exercise had 0 high risk plaque. In other words, they would be at much lower risk of events. So this is what the slide is summarizing, that moderate to high exercise reduces the severity of blockage. In other words, even though you may have calcium, the blockages are less, and you will have lower risk of having a high risk plaque. This is an individual from that study, 62-year-old male, high exercise group. Here is a coronary CT angiogram, which you don't see that clearly, but there is amount of calcium out there. But this is laid out here. You can see the blood vessel. There is calcium in the LAD, which is causing less than 50% blockage. And this person is likely to do well. On the other hand, this is a 67-year-old from the inactive group. He's got a soft plaque in here. You can see that it's not calcified. This is an expanded picture of that blood vessel through imaging, and you can see that this is the soft plaque out here. This is the lumen. So this person would be at higher risk. So I have to talk about this study because this comes from Cooper Clinic. How many of you know where Cooper Clinic is? So Cooper Clinic is just north of us in Dallas. They do some good work. And they took about 8,500 patients. And they said, we're going to look at two factors. If you have calcium, does it predict mortality? Does it predict the chances of you having death, heart attacks, being admitted to the hospital with chest pain, stents, bypass surgery? And then see if that calcium buildup risk is attenuated by how fit you are. So in other words, they actually measured what is called cardiorespiratory fitness. How do you measure cardiorespiratory fitness? So let's talk about that. How can you decide how fit you are? And you measure that by what is called metabolic equivalence, MET. If you take an Olympic athlete and he's consuming, let's say, this much amount of oxygen at rest when he's just resting, he can increase that oxygen consumption up to about 20 to 25 times. Okay? A kind of average Joe Blow who thinks that he's a very good cyclist can increase it by about 10 to 15 times. This is the highest cardiorespiratory fitness group, which is 5. This is more like sedentary group. They can't consume much oxygen. You can see that the fitter people were younger, they were thinner, their blood pressure was lower. Okay? In addition, the younger people had lower blood sugars, lower risks of being diabetic, higher amount of good cholesterol, lower amount of triglycerides. So this is another indication telling you that fitness matters. When you're fit, you're less likely to be a diabetic, you're metabolically more healthy, you will have lower weight. This is their calcium score here. This is black line is 0, the red line is greater than 400, and then there are intermediate scores out there. This was adjusted for age, smoking, diabetes, body mass index. In other words, this is only in relationship to cardiorespiratory fitness. If you are fitter and you have a high calcium score, what is your risk of having an event? So the first slide, the first portion of this graph is looking at 5 years of follow-up. So let's take this line. This line, people have high amount of calcium, greater than 400. If they are not fit, so now this cardiorespiratory fitness is measured in METs. What did I tell you an Olympic athlete can increase his MET to? If somebody is 1 at baseline, at rest, what can they go up to? About 25. Amateur athlete can take it up to about 15. Okay? So of course these were all amateur people. So if you were not fit, the chances of you having an event in 5 years was about 23. Despite, because you had the high calcium score. But despite having that high calcium score, if you were fit, it dropped to 11. Now, if you had 25 years of follow-up, in other words, you projected this out to 25 years, if you had a high calcium score and you were not fit, the likelihood of you having an event is almost 50%. On the other hand, if you were physically fit, it was about 18%. This is somebody from our practice. This is a nice man. He is into endurance exercise. He's 70. He does a lot of yard work, all kinds of movement, either running, cycling. He's got low triglycerides, high HDL. He's insulin sensitive. But he has extensive calcium. Look at that. This is the LAD. You can see a still image of the LAD, but as I played, LAD has calcium. Left main has a little calcium. This is the right coronary artery that also has extensive calcium. So we took him to the cath lab. In fact, his calcium score was almost 2,000. So this is the blood vessels of the heart. This is the LAD. That's the right coronary artery. There are no blockages. even though you can be an exception in the sense that you may have high calcium score, but you may be metabolically healthy and physically fit, and the calcium may have lower impact on you than if you are otherwise. Now this is a 66-year-old lady who's diabetic, who's got a high calcium score of about 4,000. And on the stress test out here where these arrows are, there's a little bit of reduction in flow with stress. And on this calcium scan, you can see extensive calcium in all the blood. But this is the LED. It almost looks like bone. And then you can see that the circumflex and the right coronary artery especially, lot of calcium. Now when we look at her blood vessels are not as healthy as the other person's. So in this patient, I'd be extremely leery and very careful in saying that, hey, you need regular follow-up. If you have even the slightest degree of symptoms, you're likely to progress, and that you should be careful with your lifestyle.
Dr. Ali, going back to the first one, the 67-year-old male that did very, he had a high calcium score, but his coronary arteries looked great. Could that be accounted for by the plaque or the calcium being on the exterior of the vessels?
Probably, which is what's called vascular remodeling. In other words, the blood vessel enlarges to accommodate the plaque. Exactly, which is the point, and I'm glad you got that point. We know that fitness is good because it attenuates the risk of high calcium, it reduces cardiac events, it increases good cholesterol, it reduces fat in the blood, it improves your blood pressure, reduces body weight. Now, diabetics and calcium have a special relationship. So in other words, does diabetes worsen the risk of you having coronary calcium? So here is a trial of about 10,400 patients, of which 900 were diabetics. The diabetics at baseline itself had a high calcium, 281 versus 119. They were followed for about 5 years, and what they looked at is mortality, the risk of dying. Does it surprise you that you have calcium and diabetes, that your risk of dying increases enormously? In 5 years, 7% were dead, whereas with no diabetes and calcium, only 2%. Okay? Now, these are the divisions. In other words, less calcium, greater than 1,000 calcium. This is non-diabetic group. And you can see that the risk of dying in the highest calcium group in non-diabetics at 5 years was 13%. On the other hand, if you were diabetic, the risk of dying in the highest calcium group at 5 years, at actually 3.5 years, because they, many of them, they stopped observation, was 20%. Much more dramatic. On the other hand, and this is what I put it up for, if you're a diabetic and you have a 0 calcium score, you behave pretty much like a non-diabetic. So in other words, there's some people who are diabetic who are lucky enough to have a 0 calcium score who don't have any increase in mortality. You asked that question, here is the answer. How does exercise benefit? And exercise benefits because when you exercise, the thickness of your heart increases. So in other words, the heart muscle thickness, and I've seen it in a lot of my friends who are cyclists who come get ultrasounds done at the office. You can see that the thickness of the heart muscle is greater in both the septum and in the back wall of the heart in athletes compared to sedentary people. Also, the heart is a little enlarged. So in other words, when the heart is a little enlarged, it works a lot more efficiently, especially if the heart muscle is thick. And so here you see the enlargement of the heart. But what is the most dramatic thing is on this slide, which is that the size of the blood vessel increases. So in other words, this is the main blood vessel of the heart, which is called the left main. And in this group, the size of the left main. In other words, the diameter of the left main was compared between the sedentary individuals and athletes, and it was larger when they were resting, but when they were exercising, the increase in the size was much more dramatic. So in other words, these individuals can enlarge the size of the blood vessel much more with blood flow. So why does that happen? It happens because of a phenomena called shear stress. So when blood is flowing through the blood vessel, it creates pressure on the wall of the blood vessel. And when it creates pressure on the wall, it gives a stimulus for the blood vessel, along with many other factors like nitric oxide, to enlarge. Now, if a blood vessel is enlarged, can it accommodate more plaque? Yes, it can. Studies have shown, this is a paper by Margaret Brown, in which she says that the blood vessels, the larger blood vessels, the left main, they increase in size. And the smaller blood vessels, which are called the capillaries, which kind of bathe the muscle of the heart, they increase in number. So in other words, you supply more blood to the heart muscle by increasing the size of the major blood vessels and increasing the number of the smaller blood vessels. There is just one point that I have left. There's about 5 minutes left. I'd like to go through this because it's kind of important. Many of you take vitamin K2, right? How many of you take vitamin K2? I take it. And why do you take vitamin K2? But I always give a reason behind it, right? I just don't tell you to take it because I want you guys to have critical thinking ability. I will not go through the slides for the sake of brevity because I want to finish on time. What vitamin K2 does is that it activates an enzyme in our body, a protein in our body called MGP, and when it carboxylates it and when it activates MGP prevents calcium buildup in the blood vessels and helps calcium buildup in the bones. At least that's the theory. But the evidence that this happens, and I will show you in 3 or 4 slides, but I'm not going to because of time, is that really the evidence is flimsy. Whether it works or no, we don't know for sure. But I do still continue to take vitamin K2. Okay, so this was the evidence which we skipped through. So we summarize. So what we summarize is that higher your calcium score, the higher your risk of dying or having a cardiac event. If you are both diabetic and have high calcium score, your risk is severely magnified. There is a significant power of 0. A lot of women have 0 scores, but having a 0 score, don't suspend common sense. If you have a fatty liver, if you have high triglycerides, you're not safe. Cardiac fitness reduces the risk of coronary calcium. So in other words, I'm happy because I do have coronary calcium, but I do have some cardiac fitness. So that reduces your risk of coronary calcium. Endurance exercise, like the kind of exercise I do, my friends do, can increase our coronary calcium, but that risk may be attenuated because there is vascular remodeling and there is also improvement in your metabolic health. Diabetics with 0 calcium score still have a 0 risks. Now calcium score and statins. What do you think about statins? They increase calcium in the blood vessels and they kill the cells that line the blood vessel wall. Statins reduce anti-inflammatory proteins. Vitamin K1 and K2 may reduce coronary calcium. The evidence is flimsy. The calcium scan is a low-cost, low-radiation test. I agree with that. How frequently should you get calcium scans?
Once a year?
No, once a year is too much.
3 years.
So if you have a 0 calcium score, like some of you do, some of the women here have 0 calcium scores, they can get it done every 4 to 5 years. If your metabolic risk is high, in other words, you're a diabetic, you want to know what's happening to you, getting it more frequently, about once every couple of years, is reasonable. Getting it every year, I think, is too much. High calcium score with symptoms, very likely to have coronary artery disease. High calcium score with diabetes, same thing. That's all I have. And you finished 3 minutes ahead of time. Okay. So you have to have a question for Dr. Jarudi. He's come second time, so I'm really happy that he's here. Yes, sir.
Endurance exercise, how much you can find it? How much in a week?
How much in a week? The high endurance exercise people did upwards of 6 to 10 hours. That's how much they did. My cycling friends who are very good cyclists do about 15 to 20 hours per week. I managed to do 10 hours in a good week.
That's a lot.
Yeah, that's a lot. Yes, sir.
So a question on the calcium scores. When you first stated you were not metabolically healthy, and then you changed your life, you got healthy. I've read and heard that you may get a spike in your next calcium score because you calcified everything and that you maybe slow down. Is that the case?
It's possible. So what you're saying is that you're using the statin argument, meaning that you had plaque buildup, you were unhealthy, you exercised, and you did the right diet, you did fasting, so your plaque stabilized, and stabilization of the plaque is associated with increase in calcium score. I don't buy that, but let's take that as an argument. Then yes, you would be at lower risk. You would be at lower risk just on the basis of your metabolic fitness, metabolic health, and cardiorespiratory fitness. In other words, the fitter you are, the lower the impact of calcium. The more metabolically healthy you are, the lower the impact of calcium.
But you don't buy that it's stabilized.
At least I don't buy that argument that calcium stabilizes the plaque.
Is that because of a lack of studies? Or
It's lack of studies and,
What does it even mean?
exactly.
means it doesn't break off and make a stroke? Is that what you mean by that?
So the thing is that the calcium is not going to break off and plug a blood vessel downstream.
Okay.
What's going to happen is that plaque is going to rupture. Rupture means that it's going to break open and form a blood clot at the spot where the plaque is and cause a cardiac event. So if I believe that calcium causes stabilization of the plaque, then I would be giving everybody a statin. So go ahead, James.
Just a quick question on the vitamin K,
Uh-huh.
vitamin 2. Is the evidence flimsy because it's just something that just started?
Excellent question. Excellent question. There's not enough evidence because the studies are small. So in other words, if somebody really wants to take that up, like vitamin K cannot be marketed, K2 cannot be marketed effectively. It's not like a lipid or drug. So you need good studies, and the number of studies that are there are very few. So the evidence may just not be there. Yeah. Go ahead, Kathy.
What makes plaques rupture? What sort of things?
Very good question. What makes plaques rupture? So in other words, you have a plaque, a soft plaque or whatever, highly vulnerable plaque. What would make it break up and form a blood clot out there? So many factors implicated. Stress, lack of sleep, poor quality cholesterol, high triglycerides, low HDL, being a diabetic, high blood pressure. There are many other factors that we don't know. So try to avoid all of those, as many as you can do. Yes, sir.
Dr.
Mr. Adams.
What would you say to patients who have high calcium scores, but apparently it seems to be vascular remodeling going on?
I would tell them that, look, you have high calcium score, follow the literature, become metabolically healthy. That means drop your triglycerides, increase your good cholesterol, become physically fit. If you are a diabetic, change that and become a non-diabetic. That is the best advice you can give them. In terms of drug therapy, I'm not sure that there's any drug therapy that can actually reduce calcium score effectively. So it's all about lifestyle. Go ahead, please.
So you are saying that a lifestyle improvement can improve the calcium score?
So this is a good question. So many people come and ask me and say, can you have regression of calcium score? In other words, can you reduce the amount of calcium buildup in the blood vessels of the heart? And Gabe and I have seen literally hundreds of patients with repeat calcium scores. And so far, I have not conclusively seen anybody with a meaningful drop in calcium. So I have not seen regression. But there is enough data I showed you, lack of progression. In other words, if the calcium score does not go up, you behave almost exactly like you have zero calcium. So we have seen stabilization.
So would you say it's significant, like, if I go in, I'm 63. If I go in and I have a calcium score that's almost medium, I've never had it done, I don't know. And I stop the increase, okay, in 5 years, then now I'm higher on the age bracket like you showed in the charts. So it's like I'm more like of a younger, you know what I'm saying? It didn't
Correct.
get worse,
Correct.
but I'm older.
Correct. So you are in the better percentile. You are in a better peer group. Absolutely. Yes, Jean.
So, what I'm gonna ask is, once your plaque has built up, once you start building plaque, let's just say, it can get to a certain point and you can stabilize it so that it doesn't go further and become a greater risk to you.
So yeah, potentially you could do that. How are you proposing to do it?
Well, you know,
By luck or by some intervention?
throwing that penny up in the air? No, of course by lifestyle change.
Yeah,
Probably
absolutely.
exercise.
I think the evidence is there that you could do that.
Thank you.
Go ahead, sir.
Kind of an obscure question. Supposedly around 30% of people who have heart attacks, their first symptom of a heart attack is heart attack.
Correct.
So in looking at these people, can you look back and go, well, that was a clue, that was a clue, that was a clue, you just didn't
Yeah.
see it. Do you do that? Do you have things?
Yeah.
What are they?
You could do that. I mean, you almost often wonder what was it about these people that made them have a heart attack. Yes, definitely.
And what do you conclude?
I would conclude that many of these people had poor metabolic health, they've had high amount of stress, they were physically inactive. So you will find many of these factors as a constellation, as a group.
What you're saying is heart attacks just don't happen.
Yeah. Now, heart attacks can happen in athletes, but mostly that's because of a coronary anomaly. They're born with a strange coronary artery or they have hypertrophic cardiomyopathy. So yes, it can happen in those groups too.
Thank you.
Go ahead. So I will take about 2 or 3 more, let's say 3 more questions, and then I'll stay here and answer questions individually because I don't want to keep the whole group. Go ahead at the back.
As far as statin goes, does the amount that you consume, like if you're on a low, versus is it the higher, the more you take, the more worse it's going to be versus if you're on a low dose?
So the higher the dose of statins, the more likelihood that you will have side effects, the more likelihood that you'll become a diabetic, the more likelihood that you will have cognitive impairment, the more likelihood that you would have reduction in libido. In other words, testosterone, estrogens, and all that. Whether higher dose will also increase your coronary calcium, that information is not there. Okay, 2 more questions, then we go. Yes, sir, Mr. Spencer.
How do you reduce triglycerides?
So here is a very good question. How do you reduce triglycerides? Okay, so what is triglycerides? Triglycerides is fat in blood. If you have lower amount of fat in blood, that means you're fat burning. And so the best way to reduce triglycerides is to eat less carbs. Because when you eat less carbs, the body resorts to burning fat. The other way to reduce triglycerides is to exercise. And when you exercise, you are burning more calories, you're mobilizing fat, you will get rid of your carbohydrate stores which are limited in supply, and that's how you can reduce triglycerides. The third way to reduce triglycerides is fasting. When you fast, within about 18 to 24 hours, you will consume all the carbs that your body has stored and you will resort to fat metabolism. Now, after having said that, there are certain individuals who have high triglycerides, who are also high insulin or take a large amount of insulin, who are insulin resistant, and these people, if they go on a low carb but a high fat diet, they don't benefit immediately. The reason they don't benefit immediately is because their fat cells are full. So in other words, their fat cells are full and the fat is spilling into the bloodstream. And when they eat more fat, the body has no place to pack the fat into the fat cells. So the body says, I'm going to leave it in the bloodstream. So if you are, let's say, very insulin resistant, if you have high triglycerides, if you are a little on the heavy side, you need to be careful about a low carb diet. What you first need to start is a lean low carb diet. A lean low carb diet is mostly eating protein with minimal fat and minimal carbs. That way you're burning the internal stores of fat. So it's an individual decision that, you would need individual counseling in that situation. So not everybody with high triglycerides can go on a low carb diet and reduce their triglycerides.
So a lean, low-carb diet, would it be true that you just don't add fat? Don't you just eat like your meats and you just,
No,
it's
but
gonna have some fat?
you could eat a ribeye steak that is filled with fat. You could have a marble steak that has a lot of fat. So you will start needing to cook your food in such a way so that you're removing fat from it. So a slow cooker is a good way to cook it, like an Instapot. You cook it, let it sit, the fat floats to the top, you take out the fat, what you're left with is lean stuff. An air fryer is very good. I use an air fryer a lot. It does a good job. So you would have to work to reduce your fat intake, which is very hard. To go on a lean low carb diet, you have to have extreme willpower. You can do it only for a short amount of time, like 1 to 2 months. It's not easy to do. Last question there at the back.
Going back to statins, you said the high milligrams give you those symptoms. What about low milligrams with a long period of time of taking the statins? Does that give you the same symptoms?
No, the lower the dose you are taking, the lower the risk of side effects. But you should also remember that low dose can have side effects in different people because, like, let's take women. Women have low muscle mass. So they may have side effects at a lower dose. You take a strong person, they have high muscle mass, they may be okay with the medium dose. So it should always be that I take it and I monitor for side effects. So I'll still stay here. You guys can come and ask me questions. Only exception would be if you have a question for Dr. Jarudi, then we'll take one. Anybody?
Thank you so much. It was a great
Oh, good. Thank you. So we'll be here next month.